welcome. And I'm looking forward to talking to you about cognitive remediation. I'm here with Gregg Pauletti for a conversation about its proven benefits, and I'm really glad you're here. We're going to give everyone a minute to join us. So please drop your location and a little name and intro into the chat in the meantime. And we'll keep an eye on the chat. Hey, Jerry, nice to meet you. Hi, Maria.
Yeah, they're
very good.
Starting to come in.
Yeah. Hi, Jeanette. Ooh, Lake Forest, Illinois. Very good. Jeanette, is it more of a lake area or more of a forest area?
Georgia.
Yell at me if I'm mispronouncing any of these. Welcome. Oh, Georgia. Okay. Oh, Nancy Januzzi. Listen, I have ancestors of the Januzzi clan. We're probably related. Nice to see you. Oh, cool, Jerry. All right. Robert Louis Stevenson School. Excellent. Excellent. I read the story Treasure Island to my 5-year-old all the time. Christina Reddington, welcome. Wellspring, Connecticut. Excellent. Rachel, Freedom Institute. Nice to see you, or nice to see your words.
All right.
Hello, Eliamonic. Nice to meet you. Sorry if I said that wrong. AJ Diaz, good to see you. You were accountable. Anyone else out there want to say hello? Because we're going to start in a minute. All right, well, let's get started. So I'm Jeremy Ware. I'm a clinical supervisor at the dorm in New York City. I've been a therapist for 11 years and been working with young people for 25 years, and with background in sort of CBT and motivational interviewing and that kind of thing. I'm very excited to be working at the dorm. And, you know, I got interested in cognitive remediation, and I think part of my background as a middle school teacher drew me to it, but I didn't really know a ton about it. And I was very lucky that the place where I work, the dorm, is really into research and training. And they sent a bunch of us to get extensively trained by a guru in cognitive remediation. I'm very honored to have that guru with us. The person who kind of wrote the book on, who literally wrote the book on the NEAR model, which I'll ask Gregg to talk more about. Gregg worked extremely closely with basically every day. So you cannot really get closer to the founder of this. And Gregg is really excellent at that. So I'm just going to quickly introduce him, have him say hello, and then we'll get started with the presentation. So this is Gregg Pauletti. He's an educational consultant and founder of the RCHI group. He's an independent educational consultant who specializes in working with young adults who are living with mental health challenges. He's got a background in counseling and higher ed, and an in-depth knowledge and experience supporting individuals with executive functioning needs, study and life skills, and other challenges that face young adults living with mental health. So we're excited to have his extensive knowledge with him. And Gregg, if you could just say hello.
Yeah, Jeremy, thanks for having me. This is exciting, and I really appreciate you inviting me to talk about cognitive remediation, which, like you, is one of my passions. You know, I was trained, I guess, 7 or 8 years ago by Dr. Medaglia, who's brilliant and understands and developed this particular model. And I was lucky enough to work with her and learn it myself and you know, develop and lead programs. And now enjoy working with you know, places like the dorm and others to kind of bring this type of program to other places and make sure that it's available to those who need it. So this is exciting, and I'm glad we can spread the word.
Okay. Thanks, Greg. Okay, so quick housekeeping. This is going to be about 40 minutes, this presentation, and we're going to have questions and answers at the end. You can drop things into the chat at any moment. There's also a Q&A. So feel anywhere you want to just plop your question, we'll get to it. And you're going to receive slides and recording after the presentation, along with all of our contact info in case you want to keep the conversation going. Okay, so without further ado, let's pull up the presentation. Okay, so cognitive remediation, a proven strategy for strengthening psychosocial function. The benefits of cognitive remediation have a broad function. So here we go. This is what we're going to do as an agenda. I'm going to do 2 quick case studies showing CogRem, we call it. So I'm going to say CogRem. So it's cognitive remediation, but from now on, I'm just going to say CogRem. Insider term I learned from Greg, right? So I'm going to do 2 quick case studies that you really see the way it works. And if the technology works, I think it will, I'm actually going to try to ask you to sort of play along in a little game with me so you get a real hands-on experience of what it's like to be a group member in one of these classes. And we're going to talk about the origins of CogRem and the impact of CogRem. And I'm going to leave a good amount of the origins to Greg, since he's the expert and I'm sort of a seasoned, crusty therapist, former school teacher who's trying to fit this into an already very effective program, and I'm really excited about the results that we're seeing so far. So let's jump right into a case study. And I'll quickly just define the terms before we do. I'm sorry, you can go back, Elizabeth. Got ahead of myself. Just quickly, I'm going to define it just in case there's anyone here who has heard the term but doesn't really know what it might be. And I was certainly in that category before I met Greg. Just quickly, it's a type of therapy that uses games to strengthen cognitive functioning for clients. So very briefly, you'll have a group of people who've been identified as having some sort of cognitive impairment, right? And that can happen for a number of reasons, but that's the one thing you kind of need to have to benefit from this. And so that can come from depression, from psychosis, from eating disorders, from personality disorders, a whole host of things, brain injuries, right? Some sort of cognitive impairment in which your brain isn't working the way it used to or the way you'd like it to. So what we do is we do an adapted version of the NEAR model that Greg's going to talk at length about. But basically, it's just they play a bunch of exercises on a computer. They each have their own laptop, and they're tailored to the specific needs of that client. And we do testing beforehand to find out exactly what they need. And there are 2 programs that we use. One is called Brain HQ, and one is called Happy Neuron Pro. Brain HQ is sort of like prettier, and like Tom Brady, the football player, endorses it. I don't know if that's going to bother you, AJ, out there, particular person I know. And then there's Happy Neuron Pro, which is not as pretty. It kind of has a 70s font to it, but it's actually a little easier to use in some ways. So whatever, we don't have any particular relationship with these companies. There are others out there, and Greg is a good resource for those. So let's jump right into the case studies. So case study number 1. This guy, Tony, this is a real person. This was one of the first clients we had. I actually think he was the first client we had in CogRem. We were getting extensively trained by Greg and going to all these talks and reading books and everything. And we finally met someone who really wanted to be in it, but we hadn't started yet. So I met the distraught parents of this 29-year-old guy. He had OD'd on fentanyl 3 months earlier and had a traumatic brain injury from lack of oxygen. And it had essentially lost his ability to follow a conversation, right? Or really interact in anything close to the ways he used to be able to do. And so they would come in, they were filled with anxiety. They would talk, can you help our son? Can you help our son? And he just kind of sat there. And I was sort of, listening to them and watching him and watching the way he was responding and, not really nodding along. And so I asked if we could, he was quiet, very quiet, but he had this gentle demeanor that didn't really match had kind of rather loud clothing. He had these, bright gold sneakers and a giant chain. It was sort of like you could sense that there was this personality in there that was used to getting expressed that was not being expressed. So I asked the parents to step outside and I talked to him for a little while. because he couldn't really seem to keep up with what we were talking about. And his eyes were a little glassy, and I actually wondered if he were high in that meeting. So he waited. I asked him some questions about his past and what he was here for and what he was experiencing. And he couldn't really, I don't know, he waited a long time to respond, right? And if you've ever had I had a stepfather who had Parkinson's, and late in the course of that disease was very similar to that he couldn't keep up with the conversation. This was a person of great wit at one point. And so you'd have to really slow down and just wait, right? And he was like that, and he would respond, and he was in there, but it just took a long time, right? And so he confessed he'd relapsed recently, and his parents didn't know, and he didn't really want to be in treatment. And I know you've all heard these stories before. And he was just here to keep his terrified parents happy. And the only thing that they really agreed on was that his brain wasn't working the way it used to. And we didn't have it fully set up yet. And so we sort of got him in the program and sent him to a bunch of groups, and he got a bunch of support. And then we started the program. And so he showed up to groups, and we tested him and opened the group. And he spent a good part of his time here playing one game. And the game is called Root It Out. And so this is the game I'd like you all to try. I'm going to ask you to join me in playing it. I don't know, do I have the ability to get a volunteer? I'm not sure if in this format I can do that, but you know what I'll do? I think I'll just ask you in the chat. I think easier than that, I'll just ask you in the chat to type in some answers. So I'm going to share my screen. Disabled screen sharing. Elizabeth, I think you accidentally just disabled screen sharing. Can you re-enable that? Thanks. Okay. All right, so can you all see that? Send me a yes in the chat if you don't mind, because I can't see any faces. Where'd the chat go? Okay, thanks, Jerry. Okay, perfect. Here we go. We're just gonna start the game. This is for verbal memory, which just means remembering words. And this is part of the process that will happen with someone who's having some cognitive impairment. You can't think of the word, right? So here we go. We're gonna look for common nouns made up of 4 letters for 2 different roots. And here we go. So type in some words, 4-letter words that start with WH and WA. Please type them in the chat, and I will type them into the game. I see what, typing what. Oop, I lost the chat. Where'd the chat go? Forgive me, I can't find the chat now. There it is. Thanks. Want. Okay, I see want. I see whale. Oh, good one, whale. Okay. Wand. What? Okay, thank you. Whom? Linda, good, very good. Whom? Oh, they don't want whom. They're finicky sometimes. What do we got? Warren, I see Warren, thank you. Christy, thank you for wash. Christina, walk, very good. Ward, I definitely would not have thought of Ward. There we got wall, good. Wash. What are we missing? When, okay, good. Oh, good, wait. Okay, where, that's my name. How did I not think of that? Wham, okay. Wham, whip. Wasp. What am I missing? Warp, good one. All right, we got the WAs. We still need a couple for WH. Did I miss any? Kim, I see yours. Wham. What? When? Someone help me. We're going to run out of time. Oh, whoa. Good one. Rachel, thank you. Whoa. I see that one. Whim. Excellent. Michelle, thank you. 2 more. Were. Very good. WHOP, is that a word? Sorry. WOP, that does not count. Oh, wit, good. We did it. Okay, thank you. Okay, so that's it. So it's kind of fun. Part of what we want this to be is we want to engage them because they have a ton of anxiety and stress and also shame about this. So one of the things that Gregg really stressed with us when he was training us was that we make it fun for them because, you know, it's a touchy topic, right? And so, you know, we have music playing when they walk in. We make the room very comfortable. They can sit in any position they want. They have a laptop. They can use headphones. And we really do try to make it fun. We try to keep it light and play games, but there's real work going on at the same time. So if you could, Elizabeth, let's go to the second case study, if you could. And I'll do the same thing. So, oh, I'm sorry. You know what? Thank you. I forgot. I wanted to show you the results. So these are the results. If you can see on your screen, the top half, so there's two scores. The pre-test scores are on the top, and the lower half has the post-test scores. So as you can see, this guy came in all very low, really one of the lower, you know, sort of test ranges we've had. The only thing he was doing okay with was reaction time. But if you look down at the bottom, if you look in the bottom half, if you follow the sign over composite memory, verbal memory, and visual memory, which were the things we were focused on, as well as reasoning way down, really went, average means normal. So he was completely recovered in his ability to do those things, his memory. And you could see it because his wit came out. He started cracking jokes. He turns out he was kind of an obnoxious, nice guy. I liked him, but he had this sort of obnoxious, like nudgy personality that we all didn't know, right? It was sort of like a welcome back, nice to meet you kind of a thing. And truthfully, this person had pretty poor attendance compared to the other clients. So I was a little nervous that this was going to throw the scores off. I was stunned and thrilled to see these because this shows that even if a person is only, you know, somewhat willing and attendance is not great, if you're spending months doing, this person was in the program for 5 months, it really should have only been 4, but he was in it for 5 or 6 actually because he missed so many days. It still really worked. And so anyway, so I just wanted to show you those results. And I think we have time for a quick one more. Okay. So Elizabeth, can you show us to the next one? Okay, so case study number 2. This was a 19-year-old young woman who'd been referred to multiple programs in hospitals, leaving them due to, you know, volatility. Maybe you've had clients like this, you know, they're suicidal, they're using substances, they're getting in sort of sexual entanglements with other clients, sometimes refusing to speak, you know, and, you know, at the dorm, we try to sort of be the last stop for folks and really, you know, try to have this be a place where they're not going to be referred to. We're going to tolerate some of this chaos and try to make you feel contained and supported, and, you know, give wraparound services. And she was a big success in a lot of ways, except for her academic ability for a while until we brought in CogRem. So she'd been in our program for 2 years. She'd stabilized enough that she wanted to go back to school, but she'd utterly lost the ability to concentrate on what she was reading. And if you've ever had that experience of getting to the bottom of a page and you don't remember a word that you just read, I think I've had that. We probably all had that. That was all she had as an experience. She decided she was stupid, which she definitely was not. And she got frustrated. And I knew she was. I mean, she even had the first day I met her, she wore a shirt that says, good writing is sexy. I remember that. And so I knew that there was this appreciator of literature in there, and she couldn't read. So it was sort of tragic in that way. So anyway, she spent most of her time playing a different game, and I'm going to grab that game for you right now if I can. So I'm going to share my screen. Let me find that one. Let's see if we can get that one open quickly. Bear with me 1 second. Okay, share screen. Okay, tell me if you can see this one. Tell me in the chat, please, if you can see it. Thank you. Okay, thanks, Michelle. Thanks, Cicely. Thanks, Kim. Okay, here we go. We're going to start this game. So this was the game that she worked on. Okay, so this is about, you know, this is about remembering what you read, sort of what you would call in an SAT test, reading comprehension, right? So This is Elaine. Her favorite color is brown. She works for the FBI, right? So try to retain those. We would call that working memory, short-term memory, right? Try to retain those because you're going to be asked about them. Okay, Elaine, favorite color brown, works for the FBI. This is Selena. She works as a translator. She lost her cell phone yesterday. And of course, some people will understand better because I'm reading aloud, and there'll be others who can only see the words and they don't process that well auditorily. So keep that in mind. So remember, Selena, translator, she lost her cell phone yesterday. Okay, so here they're giving you the real answer. Now the real one starts. So that's just an intro how it works. So here we go. This is Sarah. She's writing a cookbook. She lost her new coat yesterday. Everyone got that? Cookbook, Sarah, lost new coat. Here we go. This is Selena again. Welcome back. Translator. She lost her cell phone yesterday. Which one? Which answer applies to her? Her name is third. Correct, Michelle. Thank you. Thank you, Kim. Yep, lost her cell phone. That's right. What about this one? Which one is this? Cookbook, Sam, or works as a translator? Cookbook, says AJ Diaz. Correct. Correct. Thank you, Kim. So anyway, I won't spend any more time on that. But what I do want to show you is her results. So Elizabeth, could you call those up quickly? Thank you so much. So again, this is a person whose scores came. She started at a much higher level. So this is sort of more fine tuning on a very specific, this is a person who had been in treatment for a while, had experienced excellent gains at the dorm and was really, oh, Michelle says you can't see the results info. Is that true for other people that you can't see the results? The sort of the screen is black. Some people can see them. Well, anyway, I'll just highlight them verbally. It seems like some people can see them, some can't. Here we go. So what they say basically is that this person came in, if you look on the left, her cognitive flexibility and executive functioning, when she first took the test after 2 years in treatment, was doing already above average. And she was in the middle in a bunch of areas. The parts that were low were composite memory and visual memory, and very low and lower on visual memory, right? No, I'm sorry, did I read the line wrong? On verbal memory, right? That's what I thought. So her verbal memory was very low. So it made a ton of sense that she couldn't retain what she had just read. So after a few months in the program, and this is a person who had excellent attendance and strong motivation, she, at the end of the program, 4 months later, her verbal memory was completely normal. And she is now in school taking 7 classes, which I advised against, and she didn't listen, and she's doing great. And it's this amazing story that you can also target a very specific deficit. So I think at this point I've talked enough. Let me turn it over to Greg, who I think can handle the next part. So thank you, Greg.
Yeah, of course. And Jeremy, feel free to chime in and where this overlaps with what you guys are doing at the dorm as well. So I just want to touch base on kind of the areas that we're going to look at. And the dorm is a really great example of how all this kind of mixes together. So we'll kind of refer back to that, as we go along. But we're going to talk about kind of the roots of cognitive remediation, the research, behind it, why and how it's evidence-based, kind of how different theories and concepts are kind of all blended into one. To kind of get this, what seems to be, a simple game process, but is actually, a little bit more complex than we think. And then finally, what Jeremy was just mentioning and how and why it's important in the functionality that really results as a reason for it. So go to the next slide. So let's just first of all, get an understanding of what we're talking about here. When we look at mental health, oftentimes, and Jeremy said this a few times, we're talking about psychotic illness or depression, but oftentimes there's cognitive impairment. But what is cognition? So just to get a broad-based definition and understanding, cognition it's kind of our many abilities brought together And all of those things allowing us to basically take in information, to process it, to change it all around, and then appropriately respond to that information. So that is kind of I like the definition. There are lots of definitions of cognition. I think this one kind of encapsulates and helps me understand it the best. But what happens with cognitive remediation is you have to take cognition and understand why it's impaired. So the first part, that first circle, we talk about persistent problems. Those problems, that impairment, as I guess we'll use instead of problems, is connected with basically poor problem solving, both social and otherwise, as well as kind of poor ability to kind of proceed with rehabilitation services. So when we talk about rehabilitation services, we're talking about, in Jeremy's case, oftentimes it's living independently or going to school, right? But we can be talking about just a person on their own trying to find a job or keep a job. It's really kind of these services or these examples of people trying to live independently and go and do their own thing. The other part that plays a role in this is how cognitive deficits create problems in a person's ability to just like function in general. So, if you're going to be going to school or you're going to be able to work or you're going to live on your own, you have to be able to get out of bed, right? You have to be able to maintain a schedule. You have to be able to manage your time. And if a person's not going to be able to do that as a result of just not being able to put A, B, and C together, that can cause major problems. Finally, and this is perhaps the most important piece of this, when a person experiences psychiatric, an episode of a psychotic illness, or if a person experiences major depression, even after those areas, the psychiatric part is addressed, the cognition and the cognitive impairment still persists. So, a person with bipolar disorder, for example, or schizophrenia, they may be completely stable. They may be kind of, transitioning and out of, back into their normal life, quote unquote. But the issues with cognition are still there. And if we don't address those, then they're going to have continued what it might call like dysfunction when they try to go back to school or find a job. And that's what we're seeing here. And that then kind of, it becomes a vicious cycle where they may get depressed again, or they may feel like they're stupid, as Jeremy mentioned, or their confidence gets shattered. And that's where we kind of want to kind of insert cognitive remediation as a stopgap. You can go to the next slide. So where are we? What is cognitive remediation? So first of all, the NEAR model, which stands for Neuropsychological Educational Approach to Remediation, has its roots in education, or in learning rather. It's really important to understand, like when a person does cognitive remediation, we're kind of helping them take this process and relearn how to learn. We're helping them understand what their own personal learning style is. We're using the concept of errorless learning, which for all of you guys, I'm sure it's kind of this titration of difficulty levels. So we're helping them kind of move on a continuous progressive path based on their own abilities. So they don't feel like they're failing every step of the way. So we're kind of presenting the information in the games. And this is actually where the NEAR model is really critical, right? It's doing this restorative combination between restorative, which are the exercises, and compensatory or skills and strategy work or group discussion work. And we're allowing them to feel like they're and to actually succeed in each step of the way. So the confidence and self-esteem that was so low going into the program can then slowly and gradually build. And they can feel like they can achieve again. And that's why I talk about the confidence and motivation there, where it's so important. This program is so important in terms of just allowing someone to feel like they can do it again. They can then go back to school. And Jeremy, you may be able to speak if you want to for a moment. You can. How when a person gets to halfway through the program, or 10 or 5 weeks into the program, and they're like, oh, you know what? I think I want to go back to school. I want to try a community college class, or I think I want to apply to a job. And you can see it kind of come alive. Jeremy actually said literally that you could see his personality come alive. So that's really important. Jeremy, do you want to say a few things about that?
Yeah, no, just to agree very much so. Yeah, people sort of rediscovering the love of reading and so many people try to flame out in college because they just can't read, and they really want to be, they're so ashamed that they didn't finish college and they think that hurts them, and now they can do it again.
Yeah, absolutely. So, so this particular model, and I should stress, there are a number of different models of cognitive remediation, but this one in particular uses this computer exercise, we call it restorative piece, and the compensatory piece, and then blends them together. So the computer exercises, along with a discussion, which allows those individuals in the group to link what they're learning about their own, thought process and learning style and cognition, and talk about how that applies to everyday life. So that's a really critical part. I'll go to the next slide. So another component about cognitive remediation is the research. And so it is an evidence-based practice. It's been validated, but it's really interesting. So cognitive remediation, the research behind it really started in scientists looking at Alzheimer's and dementia work in care. And so they're trying to figure out how to slow down those particular diseases. And after, obviously that's been backed by research. And then they applied that to the impairment associated with mental illness and said, oh, wait a second, there's something here. And then what happened was, with the advent of the internet age and these, online cognitive exercises and gaming, and there became lots of different software and ways to kind of get this into the mainstream. That's when the research really took off, and allowed us to really look at how these exercises might apply to in settings like the dorm. The NEAR model, for a point of reference, Dr. Medaglia published her research in the book on the NEAR model in 2008. And that was kind of pretty early on. What happened was she actually used to do, before these computer exercises, use education and learning exercises. And many of you guys, I don't know the age of anyone out there, but you might remember things like the Oregon Trail, or Where in the World is Carmen Sandiego. These like really early education-based games, essentially, and applied those to cognitive impairment. And they were really impactful because they allowed young adults and people to kind of build confidence and to kind of have distal goals, and as well as proximal goals, and feel good about themselves. I put a quote up there, and it says, patients with psychotic illness typically score below 85% of the general population on cognitive tests. This is critical, right? Jeremy did a great job because he introduced this whole process by stating that cognitive remediation is effective really when cognitive impairment is present. So you have to know that cognitive impairment is actually present with the people who are going through the process. Now, does that say that any other person won't benefit if they don't have cognitive impairment? Well, not necessarily. Like, I think that feeling good about yourself and confidence and self-esteem, all that's really important, and may motivate someone to kind of move on and increase functionality. But what we're trying to do is not only increase functionality, but also improve cognition. And so when we're talking about mental illness, and we're talking about psychotic illness specifically, the cognitive impairment is present and really impactful, really impacting their functionality. So that's who we're targeting here. I'll go to the next slide. Just a quick, and I want to be mindful of the time. So the blending of these different theories and concepts. So the NEAR model is really unique because it brings in educational theory. I talked about the arrowless learning, talks about self-determination and allowing people, kind of empowering them, and allowing them to kind of choose which exercises they're using. It allows them to kind of make decisions about during the exercises that they're doing, and allows them to really feel empowered and feel good about the process that they're doing and owning it, right? So Jeremy, you might be able to speak to this, but when I'm working with young adults, I often like to use the individuals who have been doing it for a little while as the semi-leaders, and work with the individuals who are just getting into the program. And that allows them to feel good about how they can own it. They know it really well. And by being in that leadership role, it allows them to kind of take that step. And again, this is all geared toward functionality and being able to kind of take control of their own life. Interpersonal theory, so you know, the relationship that is built between the facilitator or therapist with the client is really critical. You know, allowing that trust to build up and allowing the two of those individuals to create goals and set goals and kind of move forward with that is obviously really important. And then finally, CBT is a core underpinning of a lot of what we're doing. You know, a lot of the a lot of the skills and strategies that is being presented looks a lot like CBT in terms of understanding thinking errors and automatic thoughts and understanding cognitive distortions, as well as having homework, right? So doing these exercises doesn't stop in that session. If we can, in an ideal world, we're asking them to kind of do a little bit of homework at home, do the exercises at home, think about what they're doing and process what they're doing outside of those two, ideally doing it a minimum of twice a week. Go ahead to the next session. So finally, you know, why are we doing, what is the importance of doing cognitive remediation for young adults? And this we could talk about this for probably another hour, but the most important thing is, you know, we're trying to get these young adults in to move forward and to progress within their own lives and to become young, functional, everyday adults, right? You can go to the next slide while we're talking about this, but basically, you know, when you combine cognitive remediation with other support services, like the dorm or many other programs, cognitive remediation is much more effective. To just throw a laptop or an iPad in front of someone and say, do these exercises for 2 hours a week or every day for 10 minutes or 15 minutes, that's not going to really cut it. It might be effective, and there is some literature out there that says that it does, you know, work at least to a low effect. It's going to be most effective when you combine that with other services, and you know, have a goal or a transition back into school or into a work environment. I really like it when even the strategies and skill discussion sessions are combined like in the moment with actual functional skills. So you know, in the past we've actually had a group that we moved into like a kitchen and helped teach kitchen skills and related that to cognition. Cooking is this is an aside, but cooking is really rich in terms of cognitive skills and strategies. So when you can actually in the moment present this and have the individual, especially young adults, think about it, you can have really great results. So functionality is the name of the game when we're talking about cognitive remediation. You really, that is always the goal. It's not to necessarily improve memory or improve attention, which obviously your goal is to do that, but it's what happens after that, which becomes really critical. Go ahead to the next one. Oh, that was it. So I think that, so that's actually a good place to end on, and we're obviously want to answer questions and love to get a discussion started.
Yeah, thanks, Greg. And thanks everybody. Why don't you, if you have any questions, a couple came through in the Q&A, post away and we'll try to answer them. You can put them in the chat. I will say, Michelle, you had one. Do you want to type it or Elizabeth, can we enable Michelle's mic? Thanks. And everyone else, if you have any questions, this can be the most invigorating part of the discussion. So please feed us some questions. All right, Michelle, go ahead. I think you, if you unmute yourself, I think we can hear you.
Jeremy, I think there is one while we're waiting on Michelle in the chat.
They're coming in. Thanks. Yeah, I see. Michelle, I think if you unmute yourself, I'll call on someone while you're doing that. Yael had one, which is, I don't have any mental illness or head trauma, but how can I play these games? I feel it would be useful for everybody. I'll feel that one. I guess I'll just say that a lot of people, I remember years ago, before I was even a therapist, I was playing Lumosity on my phone. There are a lot of these programs are sold to sort of the lay public as like, hey, you want to work on your memory, you want to work on your attention, you want to work on your ability to multitask or function in certain ways. And I don't know if it was really helping me or not, but it seemed to, I liked it, made me feel sharp. Gregg, you have any thoughts on that?
Brain games, as I like to call them, are kind of all over the place now. And, is it going to help your everyday person? Maybe. I don't think there's any really great research on that. I know that if you feel like your memory isn't doing so great, or if you feel like your attention could be a little bit sharper, there's no better person to identify that than you, right? And I think actually we didn't talk about this, Jeremy, but how smart you are and where your cognitive impairment is relative to the person. So you could have someone who is really, really bright and really sharp, and then they have some maybe an episode, and then their cognition becomes impaired, and maybe that impairment only brings them down. Maybe they're at like high average and they get down to low average, right? So they're still like kind of doing okay, but relative to themselves, they're not doing well, and they feel that, and so meeting them where they're at is actually really, really important. So the short answer is, yeah, absolutely. Do these games. Jeremy mentioned Lumosity. There's apps on phones. There's one called Impulse. There's Cognifit. There are all kinds of apps out there, and there's absolutely no reason not to do it. Most of them require subscriptions or licenses, though.
Great. And Jeanette had one. Is this done daily, on demand, etc.? I would say, from my point of view, we do the groups twice a week, and to Gregg's point of having some of the veterans of the group take some leadership, one of them sort of said, as if sheepishly, sort of like, hey, I'm playing these at night, is that okay? And I was like, of course, that's great, practice more. And I don't know, Gregg, I'll defer to you on what the research says about that, but I will say it did seem like people were realizing gains more quickly if they were doing it on their own, sort of bolstering it. It's it's sort of like going to the gym. If you do it more regularly, you're going to see results more quickly, right? It's for your brain, not your body. Gregg, what do you have to say about that?
Yeah, Jeremy, you're exactly right. So the literature says a minimum of twice a week, being in sessions, right, is going to be the dosage. But if an individual wants to do it more often, go to their sessions twice a week and then do 30 or 45 minutes or as much as they can tolerate throughout the week, then I absolutely would never stop them. I think that just enhances their experience and allows them to get that much more out of the program. The problems really come in is when their attendance is spotty, and Jeremy, you started to allude to that before, or when they're not really engaging in the content or the exercises. And they're just kind of doing it because they think it's a chore. And obviously then you have to unpack what else is going on there. Is it motivation, or are they having some sort of sensory or physical issue and they can't actually do the exercises? So you have to figure out what's going on there. But yeah, twice a week is what we want them to do minimum. The more often they can do it, the better they are, unless they become overwhelmed or frustrated. And that's the key part. You don't want them to do it so much that they're exhausted and they're getting frustrated with what they're doing, because that defeats the purpose of them, the errorless learning and wanting to kind of feel good about what they're doing.
Great. Question came in through the Q&A. AJ asked, can it only be done with adolescents or young adults, or can this be done with all age groups? My inclination is it can be done with all age groups, but Gregg, what does the research say?
Yeah, so when we're talking about mental illness and mental health, right, the earlier that you implement, in earlier, I mean like closer to the psychotic episode, or the kind of the point at which they realize impairment has become present, the better. So the earlier you can implement, the better. But really, the research goes from really 16 to 65. There isn't a lot of research on people who are older than 65, mostly because you run into issues related to age-related cognitive decline, and that's really hard to differentiate between what's caused by mental health or what's caused by age, and it gets pretty messy at that point. There is research showing that you can slow down age-related cognitive decline by doing things like this, or the typical thing is like, oh, do crosswords or something like that. But when we're talking about cognitive remediation, specifically the NEAR model, it's mostly effective. It's going to be the most effective the earlier you can implement. So young adults is like the sweet spot.
And Greg, Clark had a question. He felt that we might have hit some of this, but I do think there's more in there to flesh out. He asked if you could speak more about how the group interventions work, sort of this group.
Actually, Jeremy, I think this is a great for you. And why don't you explain how you guys implemented and how we helped you kind of create your groups?
Sure. So what we did was we set up the room. We do their the 30 minutes. Ideally, it would be longer, but we have such a robust programming schedule here that there really isn't time to fit in the ideal 90 minutes. So we really pack it in what they would call in school sort of like bell to bell instruction kind of a thing. Like they're in there at like 12:01 or with their computers, and they're ready to go. When we hit the 12:30 mark, we then ask them to put their laptops away. We do a little transition in which we do a very brief meditation just to kind of sort of like just signal that we're shifting gears here. We're not going to be looking at a screen. It's a little bit more of a typical group process, and that's where the teachers among you are going to have the opportunity to do some creativity, because what you really want the second half of the session to be is how do we relate this to real life? So we call it sort of the IRL portion of it. We'll sometimes do straight up discussions, right, and talk about how would your ability to focus be improved? What are some strategies? I keep forgetting my keys. What can we do about that, sort of a thing? Other times we sort of will play games that sort of involve movement and some sort of sort of that kinesthetic intelligence, that experience where they're getting up and moving around, talking about it, and because life is not lived on a computer screen, or at least it shouldn't be only. So that's what I would say about it. Greg, you want to add anything?
Yeah, having the entire environment is really important for the end result as well. So as soon as they get into this kind of group setting, you want them to transition into the exercises, and I think it's really important to know, like, people aren't just going into this room and playing random exercises that they kind of select on their own. It's carefully kind of each exercise is identified and targeted for each individual. So based on their own cognitive testing. So, Jeremy isn't going to be addressing, memory issues with someone who doesn't have any memory impairment. They're going to be focusing on the impairment that's actually present. So each exercise is selected based on what needs to be improved. And then, like you said, the transition into the discussion oriented or the linking part of the group is really, really then valuable in helping them understand based on, a whole host of topics that's been developed by, Jeremy or whatever program is doing it, and allowing them to understand, how their cognition is related to everyday life.
Right. We've got, I think we maybe have time for one more. Sophie wrote, is it common to suggest a brain scan while or before starting the therapy? I'll say, we're not a medical facility. I will say a lot of the people that we have come in here, we recommend that they get extensive neuropsychological testing. And we do, for some people that's cost prohibitive. So we have this test that gives us really specific data about what to focus on, but we certainly do that in conjunction with and in consultation with all the testing that they have previously. Greg, do you want to field that one?
Yeah, I think that's pretty common. Neuropsych is obviously going to be the best way to identify cognitive impairment. Having some sort of secondary testing is the next best way. Brain scanning, short of research studies, I don't think that's really commonly done. I think that's a lot of work and a lot for the individual to go through. When you know, you're going to get a lot of rich information from a research standpoint, but maybe not such great practical information for doing CogRem, where you can do it the same, get a lot of the similar information in a 45-minute smaller exam. So research is usually where that stuff is related to.
Got it. And let's sneak in one more, Greg. Are there specific diagnoses that CogRem works better for than others?
That's a great question. And I'm glad they asked that. So I would say over the last 5 years or so, it continues to, research continues to come out, and it feels like almost all the various mental health disorders have now shown that cognitive remediation is efficacious, right? So depression all the way up to schizophrenia. The psychotic disorders, it shows the most cognitive remediation is the most effective with. The only one that I haven't seen as far as the literature is concerned that it's really truly effective is like general anxiety disorder. And my feeling, and talking with Dr. Medaglia especially about this, is that that's typically because anxiety is so challenging to really figure out, like, where is the impairment coming from? Is it because of the anxiety, or is it because there's actually impairment as a result of the anxiety? So you know, there's evidence on depression, eating disorders, OCD, bipolar disorder, schizophrenia, and then all of kind of the subtypes associated with those as well. And then even when you get into other neurodegenerative disorders, there's also a lot of evidence supporting that.
Thanks, Greg. I was gonna wrap up, but one more quick one snuck in, so I'd like to give a chance. Daphne said, "Does this work for nonverbal learning disorder?"
That is a great question, and I just said the other one was a great question. But so I haven't seen any research, and Jeremy, I don't know if you worked with anyone who has nonverbal learning disorder. I have worked with individuals, more than one individual who happens to have nonverbal learning disorder and has been in cognitive remediation in association with their mental health disorder, and it actually has been very effective. So there's lots of variables there, and I don't, you know, without having actual like a controlled study saying, oh, this is why, you know, they improved. You can't really, you know, say that. But my feeling is that they benefited from being a part of the group at the very minimum, and they were more functional when they finished the group at the end. So the short answer is I would say, yeah, it does benefit.
Thank you. Okay, so I want to be mindful of everyone's time. We're going to close out now. Reminder, we're going to send out the recording afterwards in case you missed anything. And next week, additionally, we're going to have a discussion with Dr. David Rowe about using neuropsych testing with young adults effectively. So dovetails nicely with what we were just talking about. We'll be sending out a link to everyone this afternoon. And I want to thank you very much for sharing.
Thanks, everyone.
Thanks, Greg.
Thanks, Jim.